Hi, my name is Jennifer Johnson. I'm a physician in the Division of Infectious Disease at Brigham and Women's Hospital, and we're going to talk about infections, fever, and antibiotic use in the ICU. I have no conflicts of interest to disclose. So as a way of some background for this particular topic, I thought we would cover a few points. The first is that fever, as will come as no surprise to anyone, is a common phenomenon in the ICU. The range varies significantly depending on clinical trials, but estimates of around 30 to 70% of patients will have at least one fever during a stay in the ICU. And the fever workup is challenging. There's a broad differential, and it's difficult sometimes to distinguish infectious versus non-infectious causes of fever. Fever in the ICU is also expensive. There are estimates of a cost of course of ventilator-associated pneumonia or of bloodstream infections, other fever-associated phenomenons that range in the multi-thousand to $10,000 range per episode. And determining when to give empiric antibiotics can also be difficult. So just to cover a couple of definitions before we get into the meat of the talk, we'll use a definition of fever for this topic, for this talk, as a core body temperature of greater than or equal to 38.3 degrees Celsius, which is the equivalent of 101 degrees Fahrenheit, mostly because that's the definition that's used in most clinical trials. And of high fever as a core body temperature of greater than or equal to 39.5 degrees Celsius, or 103.1 degrees Fahrenheit. A prolonged fever, as defined in most clinical trials, is a fever lasting at least 5 days. And the gold standard for core temperature measurement is actually by a measurement through a pulmonary artery catheter, but of course that's fortunately not available for many patients in the ICU. So the other accurate ways that we use to measure temperature in the ICU include bladder catheters, esophageal probes, and rectal thermometers. And additional temperature measurement by tympanic membrane or temporal artery thermometers have been found to be less accurate. And of course, oral thermometers are oftentimes not possible to use in the ICU due to intubation. So looking at the epidemiology of fever in the ICU, there are some studies looking at what proportion of fevers are due to infection versus other causes. And there's a wide variability across studies, in part due to the variability and nature of the makeup of different intensive care units. Some are medical ICUs only, some are surgical ICUs only, and some are combined medical surgical. And certainly the patient population depends on the other services that may be available at each hospital. But the estimates range anywhere from a third to a half of fevers that occur during an ICU stay are due to infections, or at least attributed to infections in clinical trials. And fever alone has been associated with an increase in mortality for patients who are undergo an ICU stay during their hospitalization, increasing the mortality anywhere from 10% to 35% above a baseline for other patients who have a ICU stay that's not complicated by fever, again, variable depending on the clinical trial. And perhaps the most important point is that prolonged fever definitely seems to be associated with increased mortality when compared to a fever that lasts less than 5 days. And this is a significant jump from approximately 63% risk of mortality versus 30% for a more shorter duration of fever. There are other causes of elevated body temperature. So we do have the hyperthermia syndromes, which can be drug-induced endocrine causes, including thyrotoxicosis, pheochromocytoma, or adrenal crisis, and environmental with heat stroke from exposure at depending on the area, either just exposure to the environmental heat in a desert or hot area, or from excessive exercise causing both external and internal heat. There, of course, infectious fever causes, which we'll go into more in a moment, and then the many causes of non-infectious fever, which we'll talk about in a moment as well. Because of the challenges with dealing with fevers in the ICU, the Society of Critical Care Medicine, together with the Infectious Disease Society of America, or the IDSA, put out a joint statement that said that, as a part of a publication, said that because fever can have many infectious and non-infectious etiologies, a new fever in a patient in the intensive care unit should trigger a careful clinical assessment rather than automatic orders for laboratory and radiographic tests. And this is an important point in an age when we're trying to protocolize a lot of medicine, that these events for patients, there's no easy way to just kind of have a checklist for evaluation for fever. It really requires a comprehensive clinical evaluation of what's going on with the patient. So reviewing the fever curve and how that's evolved over time, reviewing the timing of recent procedures, reviewing any symptoms that the patient may be reporting or things that may be noted by the nursing staff, and then doing a careful physical exam, especially if there's an operative site to be examined, and then reviewing recent labs for other trends. So the drug-induced hyperthermia syndromes, I'm going to go through this a bit briefly. There's some additional information kind of listed on each of these, but these are syndromes that cause elevated body temperature, but that we wouldn't necessarily call fever because of the set point, the hypothalamic set point. So these include malignant hyperthermia, which is described as a rapid onset of muscle rigidity, and acidosis. It's usually triggered by inhalational anesthetics and some of the paralytic agents, and these have become more rare as we have newer and better agents to use for anesthesia and paralysis. Then the neuroleptic malignant syndrome. This can be something that's slower in onset, so that can make it a little bit more difficult to detect. Also characterized by muscle rigidity and often mental status changes. And this one's usually related to the administration of neuroleptic agents. Again, has becoming less common as we have newer and better neuropsychiatric medications. The serotonin syndrome, which is a hyperthermia characterized by hyperthermia and other signs of autonomic instability, that can also include altered mental status and neuromuscular rigidity, and can also be fluctuations in heart rate and blood pressure, which can both be elevated. And this is usually in patients who are taking serotonin reuptake inhibitors, and often in taking serotonergic agents in combination, or in combination with other agents that may have serotonergic action, or foods that may have serotonergic action. Adrenergic fever, can be caused by some drugs, non-prescription drug ingestion, including amphetamines, MDMA, and cocaine, and then also prescription drugs such as MAOIs. And this is characterized by agitation and hyperthermia, and it's typically treated with benzodiazepines. And then baclofen withdrawal, which I think is probably not becoming less common, and in some situations may be becoming more common as we see some increased use of baclofen by alternative routes, such as baclofen, implantable baclofen pumps, intrathecal pumps. So this is a syndrome that can occur 1 to 3 days after the discontinuation of baclofen, and involves muscle spasms and hyperthermia. And it's a good reason to make sure that people are always checking the patient's pre-existing home medication list on admission, so that a medication like baclofen doesn't get forgotten to be administered during hospitalization if it is something the patient has been on at home. Some other non-infectious causes of fever rather than hyperthermia include drug-induced fevers. Apart from the hyperthermia syndromes, we do see fever caused by multiple other medications, often including antibiotics, actually. Transfusion reactions, which are usually easily temporally associated with the trigger. Clot, so either DVT or PE or both. A hematoma, especially if it's large, and especially if it's within the skull, so in the brain space. Acalculous cholecystitis and pancreatitis, just due to inflammation. Aspiration pneumonitis, which can be without bacterial pneumonia, but just with a chemical pneumonitis. Stroke and myocardial infarction can sometimes cause low-grade and brief fevers, but unless it's an intracranial hemorrhage, should not be a prolonged fevers. Neurogenic fever, which can be caused either by changes in the autonomic nervous system or specific to injury to the hypothalamus, or blood that's collecting within the ventricles or within the brain parenchyma itself. And then collagen vascular disease, diseases that may be present prior to admission to the intensive care unit, malignancies, especially hematologic malignancies, transplant rejection, which should be characterized also by dysfunction of the transplant organ, so should be easier to identify. And then, of course, the catch-all phrase, postoperative fever. So most clinical trials looking at fever and looking at patients in the intensive care unit will include a definition as a cause for fever as postoperative fever. Exactly how this is defined depends on the clinical trial. There's oftentimes a definition that this is what's the attributed cause for fever for patients who have a isolated episode of fever within anywhere from 24 hours to 4 days postoperatively, depending on the clinical trial. That's not associated with any other clinical change and is transient and self-resolves, and that there's no lack of other supporting evidence for infection. So that may be called postoperative fever. The exact mechanism of postoperative fever is not definitely known, but certainly cytokine release post stress insult, as with a surgery, and even sometimes with a less invasive procedures such as interventional radiology procedures. Certainly, we do see sometimes a post-procedural fever as well. So in terms of the infectious causes of fever, we have some common and then some less common sites for fever. So lower respiratory tract infections or pneumonias would be probably one of the more common sites for infection, and certainly noted to be most common amongst clinical trials. And bloodstream infections luckily are less frequently identified, but certainly can be more serious, even than the lower respiratory tract infections. Skin and soft tissue infections, which may be independent or may be associated with a operative site. Intra-abdominal infections, especially if there's been, if there's been an abdominal surgery. An intraluminal infection of the gastrointestinal tract, so that would be usually Clostridium difficile associated diarrhea. That's really refers to mainly a specific infection. It's unusual for us to get other intraluminal infections within the ICU. Then operative site infection, which really varies depending on where the operative site is. And then a catheter or prosthesis site, which also depends on where procedures have taken place. And then I put at the bottom urinary tract infections and sinusitis. I think there is a general approach to kind of try to use these as explanation for fever pretty frequently for patients in the ICU, but these are challenging diagnoses, and I'll get into this a little bit more in just a moment as we come to those sites. So again, the most common infection sites that we're concerned about in the ICU for bacterial infections would be lower respiratory tract and the bloodstream infections. So just a brief update on lower respiratory tract infections. There was a paradigm shift in terms of our understanding and definitions and approach to the evaluation and management of pneumonia, which happened just within the last year. And so the major change, I've just sort of shorthanded here. I did put a link at the bottom of the slide here if you're interested in reading this article or getting more information on it. But I've put in what I think are the most critical bullet points for this update on this slide, which include the dissolution of the category for healthcare-associated pneumonia, which was previously something that had a pretty broad definition and in some instances ended up as a catch-all definition for many, many patients who are presenting to the hospital, which led to many patients getting extremely broad antibiotics for empiric treatment for pneumonia because of being classified as healthcare associated. And so with the change, we now have patients who either have healthcare-associated pneumonia or hospital-acquired pneumonia, so pneumonia that is diagnosed after the patient has been hospitalized for at least a couple of days, or a ventilator-associated pneumonia, so obviously a patient who is currently hospitalized and already on the ventilator before the pneumonia is diagnosed. So that's one of the big changes. And the other big change is a change to the recommended duration of treatment, antibiotic treatment for different categories of pneumonia. So for community-acquired pneumonia, the new recommendation for duration of treatment with antibiotics is 5 days. And that includes patients who are hospitalized with community-acquired pneumonia. And for hospital-associated pneumonia or ventilator-associated pneumonia, the new recommendation for the duration of treatment is 7 days. And then there's also some newer evidence that's just been published last month that even for patients with hospital-associated or ventilator-associated pneumonia, if there's any uncertainty about the diagnosis, or if the patient rapidly improves, or if there are any diagnostics that would suggest that pneumonia is either slightly less likely or less severe, such as a lower procalcitonin, which I'll get into in a moment, then super or ultra short course antibiotics may be sufficient and indeed beneficial in terms of decreasing the risk of exposure to longer term antibiotics. So in this study, patients received a first dose of antibiotics or first day of antibiotics, and then sometimes if they were doing quite well on the following day with blood markers and clinical markers all improved or quite stable, the antibiotic course was truncated and may have ended after 1 or 3 days or somewhere in that range, depending on the patient. In talking a little bit more about lower respiratory tract infections, some of these definitions, which we've already mentioned, the hospital-acquired pneumonia and ventilator-associated pneumonia. And hospital-acquired pneumonia accounts for about 25% of all ICU infections in most clinical trials, and about at least 50% of antibiotics that are given in the ICU. So it's a significant percentage. About 10 to 25 patients percent of intubated patients will develop a vent-associated pneumonia, and the risk is highest earlier in the course of the hospitalization. And the attributable mortality to hospital-acquired pneumonia is quite high, so between 1/3 and 50%. So what are the organisms that we're worried about causing pneumonia, both in terms of helping us understand the epidemiology and helping us understand the pathophysiology and treatment for these diseases? So strep pneumo certainly tops the list, especially for community-acquired pneumonia. And Staph aureus can be a problem both for community-acquired and hospital-acquired or vent-associated pneumonia. This inclusion of Staph aureus always brings up the question of whether or not MRSA could be there. And certainly we would have concern for the possibility of methicillin-resistant Staph aureus if a patient is known to be colonized with MRSA, or has had prior infection with MRSA, or has a necrotizing pneumonia, which is often suggestive of MRSA infection, or new ventilator requirements, so essentially has a severe pneumonia, which is so severe as to require the patient to be intubated and require new initiation of mechanical ventilation, or has septic shock. It is not necessarily the case that every patient even with hospital-acquired pneumonia needs to be empirically treated for MRSA infection if they don't meet any of these risk factors. Other bugs would include enteric gram-negative rods, especially in patients with vent-associated pneumonia because of the possibility of aspiration. And then the non-enteric gram-negative rods, for example, Pseudomonas. Other examples would include Stenotrophomonas and Acinetobacter, organisms that are not typical gut colonizers for most healthy people in the community, but are gram-negative organisms that can cause nosocomial infections, including pneumonia, or even bloodstream infections as well. And concern for these multi-drug resistant organisms should be raised if a patient has underlying structural lung disease or prior colonization or infection, or immune deficiency by almost any mechanism. And then certainly the category that we often brush over in terms of etiologic agents for pneumonia is viral. And recent studies have suggested that a large percentage, a much larger piece of the pie in terms of percentage of pneumonia, etiologic agents for pneumonia, is probably made up by many different viruses, including influenza, respiratory syncytial virus, parainfluenza, and many more, human metapneumovirus, many other potential viral causes of pneumonia. So some studies using rapid diagnostic tests have suggested that at least a third of pneumonias for community dwellers may actually be viral, and so we may be over antibioticing many of our hospitalized patients, or many of our patients that are diagnosed with pneumonia. So this is just to give you a clip from the new guidelines. It's a bit dense on the slide, and the reason that I put it in there is just basically to explain that it's probably a bit more than we can go over in detail verbally at the moment during this talk, but feel free to use this slide as a reference, or again to reference this paper with the new guidelines in terms of antibiotic treatment, which the citation is given below. But the idea here is that the column on the left is empiric antibiotic choices that we might use for patients who are not particularly at high risk of mortality and don't have any of the risk factors we talked about for increased likelihood of MRSA. So you might treat them with one of the following agents: piperacillin and tazobactam, cefepime, or levofloxacin, with potential for use of imipenem or meropenem if there's any particular concern for increased risk of multi-drug resistant organisms. And then the other two categories are essentially also not at high risk of mortality, so not having septic shock or new initiation of mechanical ventilation, but does have risk factor for MRSA, essentially similar drugs with the addition of a agent specifically to treat MRSA, such as vancomycin or linezolid. And then the final category is high risk of mortality or patients who've received intravenous antibiotics during the prior 90 days, which might make us concerned about the possibility of resistant organisms. For VAP, ventilator-associated pneumonia, the suggested empiric treatment guidelines include a recommendation to choose one drug from column A, one from column B, and one from column C. So the first category would be choosing a drug that treats MRSA, so either vancomycin or linezolid, choosing a gram-negative agent that is a beta-lactam, so there's a list available here, and then finally choosing a non-beta-lactam-based agent such as a fluoroquinolone, aminoglycoside, or polymyxin. And the rationale for that is that antibiotic-resistant mechanisms happen by various different pathways, and so if the patient is doing poorly, you will increase your likelihood of treating potentially resistant organisms by using antibiotics from two different antibiotic families, such as the beta-lactams, which are critically important for most gram-negative infections, and also something from another antibiotic family that could potentially treat some beta-lactam resistant organisms. In terms of evaluation and diagnosis for hospital-acquired or ventilator-associated pneumonia, the clinical evaluation is similar to evaluation for all other infections, including a physical exam, examining the fever curve, and then in particular paying attention to the ventilator settings and what the requirements for mechanical ventilation, how they have evolved over the recent past as the patient has developed a suspected ventilator-associated pneumonia. The ventilator settings and the respiratory status are the most specific clinical findings to correlate with ventilator-associated pneumonia. Leukocytosis, fever, and even chest x-ray findings, and even lower respiratory tract cultures because of the possibility of colonization are all potentially non-specific findings. And so they are pieces of information that should be gathered because especially taken all together, if they're all suggestive, that certainly does build a better case for vent-associated pneumonia. But the vent settings are really one of the key components of this and probably the first place to look. Some organisms, when we do the respiratory tract culture, almost never cause pneumonia, and those include enterococci, the viridans group, streptococci, or also known as alpha hemolytic strep, coagulase negative staphylococci, and candida. Any of these certainly can cause infection within the pleural space or operative space if it's a patient who's had surgery to the chest space or lungs specifically, or has something like a bronchopleural fistula, but they're not known to be frequent, or sometimes in the case of candida even ever, the cause of parenchymal pneumonia. It's always helpful to make sure that the lower respiratory tract sample does represent a deep sample when we're sending it for culture, and to examine whether or not it's purulent. In studies, as I mentioned, unfortunately the culture has a wide variability in terms of sensitivity and specificity for diagnosis of vent-associated pneumonia because of the possibility of colonization and of other causes for fever. So there really is no easily attainable gold standard test for vent-associated pneumonia that can be used in the intensive care unit. It is essentially a clinical diagnosis based on a number of different factors to be taken into consideration. And this begs the question of how the procalcitonin level could fall into this diagnostic pathway, and we'll talk more about procalcitonin in just a moment. Procalcitonin is a biomarker of infection. It is a precursor to the hormone calcitonin, and it rises. It's been noted to rise in the bloodstream at levels that we can detect on lab monitoring in response to pro-inflammatory states, particularly bacterial infection. So it rises similarly to other inflammatory markers such as the CRP, but seems to be more closely associated with bacterial infections than some other biomarkers, and more closely associated with bacterial infections as opposed to viral infections or non-infectious causes of inflammation. It's been shown in clinical trials to be correlated, rises in procalcitonin have been shown to be correlated with bacterial infections in patients with presenting with suspected respiratory tract infections and with sepsis, presenting in multiple different settings, in the emergency department, in the intensive care unit, in hospitalized patients, and in ambulatory patients in urgent care centers. And it's been used as an initial diagnostic in order to think about the initiation of antibiotics, especially for patients with respiratory tract infections, less so with sepsis. But in both settings, as a daily marker that can be tested and followed and used in order to guide de-escalation of antibiotics over time if the level drops quickly or drops below a certain level. I've included a reference here of a nice review in Open Forum Infectious Diseases that was published within the last year that talks quite a bit about procalcitonin and reviews all of the data on this biomarker in a nice format that's quite clinically useful. This is a slide that gives some suggestions in terms of interpretation of abnormal procalcitonin levels. I realize that it's a bit dense and the type font is small, so I'm just going to go over a couple of highlights here. But this is a suggested algorithm for interpretation of procalcitonin in the first instance in patient instances of suspected bacterial sepsis, and in the second algorithm is instances of suspected respiratory tract infections. And you can see that there's a different range for the test depending on the suspected clinical syndrome, and whereas we would be not worried about bacterial causes based on the procalcitonin alone with a level of less than 0.1 for patients that were concerned about the possibility of respiratory tract infections. We would be not worried about patients for the possibility of bacterial sepsis when levels are less than 0.5. And then in parentheses, you can see that there's suggestions for how to use a daily procalcitonin level in order to judge when ongoing bacterial infection becomes less likely. And in most cases, this is when there's a decrease from the peak value of at least 80 to 90%. When the value is low or when it decreases quickly, the suggestion would be, unless there are other clinical findings, certainly the procalcitonin is not a perfect test, and it's certainly not a standalone diagnostic test, but it does, again, provide another piece of information that can be taken into consideration along with clinical data and other laboratory tests in order to determine appropriate use of antibiotics, whether to or not to initiate antibiotics, and then at what point to consider stopping antibiotics. A couple of important caveats to this test. One is that the procalcitonin level can be falsely low when tested early on in the evolution of infection. So antibiotics certainly should not be withheld for patients who are strongly suspected to have infection on the basis of a low procalcitonin level alone, especially in the instance consideration for sepsis. And patients should receive antibiotics immediately, and the procalcitonin could be used more as a test to guide antibiotic cessation. And then the other point is that there are many patient populations that in which the procalcitonin measurement has not really been studied because they were often excluded from clinical trials, and that includes pregnant women and also patients with most forms of immune compromise, so receiving chemotherapy or organ transplant recipients, these type of situations. So we just don't have the data to know really well how the procalcitonin should be interpreted in some of these patient populations, but this is something that we're accumulating data for on a day-to-day basis, so we may have more in the future. And then based on those levels, this is one suggested algorithm for use of the procalcitonin level as an initial diagnostic. So for instance, with a patient with suspected respiratory infection, if they're not critically ill and not severely immunocompromised with other infections, and the initial procalcitonin, if it's low, could strongly discourage patients from providers from using antibiotics, but might prompt people to recheck the procalcitonin 6 to 24 hours later to see if that was just too early of a test, that it was evolving over time. And certainly if it's elevated at that point, then antibiotics would be appropriate. And similarly for sepsis, we have actually differently for sepsis, I apologize. We actually wouldn't recommend delaying antibiotics based on waiting for a procalcitonin value, but a baseline could be helpful, and that if the baseline is very low and another cause for shock or hypotension, or the clinical findings there is identified, then antibiotics could be quickly de-escalated. And then with the daily procalcitonin, once the procalcitonin is less than or equal to 0.5 or has decreased by more than 80% from its peak, then that may be an appropriate time to discontinue antibiotics unless there are other concerning clinical findings that would suggest more antibiotics are necessary. And these are some, again, the outline of the limitations which we have talked about. It's not a perfect test. There is always the possibility of false positives if patients have other sources of infection that are other sources of inflammation that are non-infectious, such as autoimmune disease or a recent surgery. And false negatives certainly can occur, especially if it's early in the evolution of the test, or potentially in some of these non-studied patient populations which are listed here. And the bottom line is that the procalcitonin value or result should never override clinical judgment, but again may provide an additional piece of information that especially can be monitored over time to guide consideration for cessation of antibiotics. Okay, so moving on to bloodstream infections. So we often use this abbreviation CLABSI, or central line associated bloodstream infections. There are a lot of bloodstream infections, central line associated bloodstream infections each year in the U.S. So anywhere between 85,000 and 350,000 depending on the year and the data, which is sometimes difficult to get. The risk of bloodstream infections with a central venous catheter is about 2 to 5 per 1,000 catheter days, as compared with less than, which doesn't sound like a terrible number, but this is compared with less than 0.1 per 1,000 catheter days for a peripheral IV. So initial evaluation should include an examination of the insertion sites daily, actually by nursing staff, and then certainly additionally by clinicians if there's concern for infection. And if the line isn't operating appropriately, especially if it doesn't flush, then that should raise some concern for clot or infection. When acquiring blood cultures as a diagnostic test for bloodstream infection, technique is actually quite important, both to improve the sensitivity and specificity of the test. And it's recommended to clean the skin with chlorhexidine or iodine, to clean the bottle tops with alcohol, to draw 20 to 30 mLs of blood. So that's one reason we do try to check blood cultures only when needed. And the optimal results are when 3 to 4 sets are drawn within 24 hours of onset of suspected bacteremia, but that's a lot of blood in a short period of time, so we often don't quite get that many, and many times don't need it, certainly if the blood cultures return positive. And it is helpful to have at least one blood culture drawn peripherally, even if another set needs to be drawn off of an indwelling central line because of lack of peripheral opportunity of veins for culture. In general, the general recommendation is not to routinely culture removed central venous catheters unless there was particular concern for infection. And there's a low rate of positive results overall of blood cultures amongst ICU patients. Many cultures are drawn, but only a scantily few turn positive. But the risk of missing a diagnosis of a bloodstream infection is so high and potentially could result in a potentially fatal error for the patient. So we do a lot of testing, even though we have only a small percentage of positive results. So in terms of treatment, blood cultures are certainly more sensitive and specific for diagnosis of bloodstream infection than respiratory cultures are for diagnosis of pneumonia. And treatment can usually be directed by the culture results, but in terms of thinking about antibiotics for empiric treatment, we would always want to be empirically treating for the most likely organisms, which include Staph aureus, both methicillin susceptible and methicillin resistant, and coagulase negative staph. Those would probably be the top two, and then other possibilities are pretty variable, include strep species, gram-negative rods, including enterics and non-enterics, such as Pseudomonas, and possibly even fungi, especially Candida, and potentially other more rare fungi, especially if patients are immunocompromised or recently transplant recipients. Line removal in the instance of bloodstream infection is certainly optimal from an infection perspective, but may not be always optimal in terms of the overall patient care, depending on what else is going on with the patient at that time. So there are some situations that we tried to get a bit more creative about bloodstream infection treatment. Okay, so moving on a bit, just to talk about urinary tract infections. Urinary tract infections are reported to be common in the ICUs, but there's no real consistent definition. Most studies equate isolation of a bacteria or a yeast on a positive culture with infection, but we know that there's a high degree of colonization with bacteria and or Candida in both the bladder and certainly on the urinary catheters and in the urinary catheter bags for patients who have indwelling catheters, including those patients in the ICU. So it's often difficult to tell if that positive culture actually represents a true infection. Genuine urinary tract infections, especially as a cause of fever in the ICU, are probably uncommon actually. The chronic urinary catheters carry a high, are associated with a high risk of patients having chronic pyuria, so having increased white blood cells on the urinalysis, and also bacteria, both actually, just by virtue of having the catheter in place. Routine evaluation of urinalysis and culture in febrile ICU patients is of questionable benefit. Certainly patients with high risk of complication with UTI, such as patients who are neutropenic or have urinary tract obstruction or pregnancy, should have testing, but it maybe doesn't deserve the high place in the initial fever evaluation that most clinicians seem to afford it. One possible way to decrease the phenomenon of overdiagnosis of urinary tract infections in the ICU is to do a two-stage process for your UTI diagnosis, initially sending a urinalysis with sediment, and then only sending a urine culture for the same patient if the urinalysis shows some significant pyuria that's suggestive of infection, and then checking a culture after that setting. If a urine culture is going to be sent regardless, then making sure to send the urinalysis with sediment with it is quite helpful, because bacteria in the absence of inflammation or in the absence of pyuria is very unlikely to represent an active infection. Okay. Other causes of bacterial infectious causes of fever in the ICU include infectious diarrhea, most commonly Clostridium difficile associated diarrhea. And this is the most common cause of infectious diarrhea in hospitalized patients, including those in the ICU. And these patients may present with fever and almost always present with leukocytosis if they don't have some other reason that they're unable to mount a leukocytosis, such as bone marrow failure in the setting of hematologic malignancy or chemotherapy, and only rarely would have absent leukocytosis if the bone marrow is working well, but does happen occasionally. And then certainly with diarrhea, sometimes abdominal pain, sometimes nausea and vomiting, and certainly with decreased appetite. Testing for this is done by assays from the stool that may be toxin tests or toxin and antigen tests, typically by immunosorbent assay, so some sort of EIA, but rarely done with a cytotoxicity assay where the stool is actually exposed to cells in culture, and the toxin from the Clostridium difficile in the stool sample can cause result in a cytotoxic effect for the cultured cells, and even the development of pseudomembranes among cultured cells. If there's a high clinical suspicion for C. diff-associated infection, then initial treatment should be initiated while awaiting the C. diff testing. And treatment for all patients with Clostridium difficile, as long as they're able to take oral medications, should be with oral vancomycin. Intravenous metronidazole is used only as an adjunct to therapy for patients who have more severe infection, especially if there's a lack of gut motility or concern that the orally administered vancomycin may not reach the intraluminal area of infection. And that may also be an indication to consider rectal vancomycin, which is logistically quite difficult to give. It's given as a retention enema. But can be quite helpful for some patients. And then certainly for patients with quite severe C. diff, especially if they have shock, then their surgical management or emergent surgical management, including the possibility of a colectomy, should be considered. Okay, what about other potential causes of bacterial infection in patients in the ICU? Could patients acquire bacterial meningitis while in the ICU? Should we be doing lumbar punctures on patients with fever in the ICU who have an otherwise negative evaluation? Probably not, unless the patients are neurosurgical patients, certainly, who are in the ICU with neurosurgical devices or recent surgery to access that space. So we don't have a ton of data on this, but the data that we do have suggests that nosocomial bacterial meningitis is probably not a phenomenon that we need to be concerned about. This was a study of 70 patients in a surgical intensive care unit that was non-neurosurgical, and they found actually 0 cases of bacterial meningitis in patients who had fever, and even with a finding of altered mental status. So lumbar puncture is not a part of the routine fever evaluation for patients in the intensive care unit. We reserve a CSF exam as a diagnostic test for patients with neurosurgical history, or those who are severely immunocompromised from advanced HIV infection or chemotherapy, stem cell transplant, et cetera. What about fungal infections? These are usually nosocomial if the patient is immunocompetent, and include invasive yeast infections as the most common group. They may have an occult clinical focus that's difficult to diagnose, and potentially even negative blood cultures. In about 1/3 of cases, we're unable to actually grow the yeast from blood cultures. And risk factors for these include prolonged antibiotic administration, underlying medical comorbidities, invasive catheters, parenteral nutrition, hemodialysis, immunosuppressive therapy, and broad-spectrum antibiotics. The most common etiologic agent here certainly would be Candida species. Mold infections with something like, for instance, Aspergillus can often have more of a subacute presentation and are much more common in patients who have underlying structural lung disease such as COPD and or are receiving corticosteroids. Do we need to do special diagnostics for patients that we're concerned about invasive fungal infections? For the most part, the fungal isolator blood culture as a specific test is not really necessary. Our most common fungal etiologic agent for infection in the ICU is Candida, and Candida species grow pretty well in routine blood cultures, and the turnaround time with routine blood cultures as opposed to isolator cultures is much quicker. And so when evaluating for candidiasis, a test for routine blood cultures and then possibly the use of serum fungal markers such as the 1,3-beta-D-glucan testing could be helpful. The beta-D-glucan is a component of the fungal cell wall of many different fungi, including Candida and Aspergillus. And when it's detected in the bloodstream, can indicate an invasive infection with one of these organisms, especially if it's detected at a high level. Unfortunately, that test is certainly has imperfect sensitivity and has pretty low specificity and can be, we see false positives in a number of situations, including administration of medications or products that are filtered over cellulose membranes, such as intravenous albumin, and also in patients who have exposure of gauze, which is primarily cellulose-based, into the intravascular space, so such as a large amount of gauze packing into an open abdomen during a time of surgery or something of that nature. Other serum fungal markers, such as galactomannan, which is a serum fungal marker for invasive Aspergillus infections, the histoplasma antigen from the urine, most commonly used, the Coxiella serology for cocci infection, can be used for immunocompromised patients who have fever or the cryptococcal antigen. But those causes of infection, those pathogens are so unlikely in patients who are immunocompetent that we rarely are ordering those tests for patients with normal immune systems. And then what about viral infections? So most viral infections are community acquired, such as the respiratory viruses that we discussed, but may include nosocomial reactivation of latent infections, such as latent infections with herpes simplex. We see patients reactivate with genital herpes outbreaks or oral herpes outbreaks. CMV, which certainly can reactivate, and we often don't diagnose that because the diagnostic test there would be a PCR of CMV from the blood, which is not a part of our routine fever evaluation. And if the patient is immune competent, so if they have a normal immune system, they will usually then clear that reactivated CMV viremia spontaneously, usually before we would get to the point of considering that as a potential diagnosis. That would change, of course, if the patient is a transplant recipient or otherwise immunocompromised and at high risk for CMV infection. And then VZV, we certainly see patients have reactivation, varicella zoster with either dermatomal zoster or rarely even disseminated zoster infection in the setting of stress from critical care in intensive care stay during hospitalization. And HIV, because we still do see patients with who are coming into the hospital with undiagnosed HIV in the appropriate patient setting. HIV as a potentially pre-existing but maybe not previously diagnosed condition should be considered when other causes for fever and infection are exhausted. And what about protozoal or parasitic infections? These are kind of clinically fun to think about and diagnose, pretty rare, especially in the ICUs, so uncommon, but there certainly are some interesting syndromes that are worth at least knowing about. Both malaria and babesia are intracellular or intraerythrocyte, so intracellular red blood cell parasite infections that could be associated with hemolytic anemia, sometimes other cytopenias, thrombocytopenia, leukopenia, and then fever and other complications including renal failure and sometimes altered mental status. They may be present as transfusion-associated infections in areas where the blood supply is not screened for these potential parasites. And then anaplasmosis or ehrlichia, which is also an intracellular parasite, though of white blood cells, which can be also transfusion-associated. And then strongyloides, which is an intraluminal gut pathogen, a protozoa, which can also be then take part of its life cycle in the lungs, and is oftentimes a latent infection that is asymptomatic, but may develop into a hyperinfection syndrome in a patient who has had latent infection, often from exposure in an endemic area, and is then treated with immunosuppressive agents, especially including corticosteroids, and that can cause patients to actually develop a severe hyperinfection syndrome, which can be even complicated by shock in some cases. So unfortunately, all of these patients in the ICU, we do see some increase in the risk of some bacteria that have developed antibiotic resistance. And there are contributing factors to the increase in antibiotic use in the ICU. One is that we have unstable patients, so we have a low threshold to initiate therapy, and that's well deserved in most cases because we know that patients that don't receive correct empiric antibiotic therapy upfront have an increased risk of complications, including death. And there's a pre-existing resistance amongst our bacteria population. Each hospital has a different sort of antibiogram or panel of resistance that they may be dealing with in their community organisms, but pre-existing resistance certainly motivates the use of multiple agents. And then we have poor diagnostic tests. So as we discussed, for both lower respiratory tract infections, especially for vent-associated pneumonia, and then even for less severe and probably more rare in the ICU, things such as urinary tract infections, we don't really have easy gold standard tests for these types of infections. And even our microbiologic data can be confusing because it may represent colonization rather than infection. So this leads to difficulty in terms of diagnosis, and sometimes we end up treating even when there's no proven infection. But even though we worry about these factors increasing antibiotic use even to the point of overuse in intensive care units, we know that delays in appropriate antimicrobial therapy increases mortality. So we saw patients who were given appropriate antibiotics in one study had a decrease in mortality from 30% to less than 15%. And then for patients with bloodstream infections, and then for patients with lower respiratory tract infections, mortality decreased by a similar margin when given appropriate antibiotics. And this cycle of antibiotic use and resistance is a difficult one to break in the ICUs. As we alluded to, we have high prevalence of infections that may be with resistant organisms. So this leads to concern for inadequate treatment, which leads to the use of broad-spectrum antibiotics, which leads to further selection pressure, and then higher colonization with multi-drug resistant pathogens. So how to break from this cycle? Limiting antibiotic use up front, especially when patients are sick or unstable, is very difficult and perhaps not clinically appropriate, especially if patients are unstable, given the risk of mortality if initial antibiotics are insufficient. But subsequent actions can make a really significant impact. So using cultures to guide antibiotics and appropriately narrowing antibiotic regimens to treat only the cultured or suspected organisms can be quite helpful. And then discontinuing antibiotics as non-infectious diagnoses become more likely also is quite helpful. And one key to this process of de-escalation and targeting antibiotics is remembering to discuss the antibiotics as a part of the patient's therapy every day, even if infection isn't their primary problem or the primary focus of their ICU stay. The antibiotics should always kind of keep a place in the sort of rounding process in the ICU, and so that the antibiotic course tailoring doesn't get forgotten amongst all the other parts of the patient's care. And then also keeping the antibiotic courses as short as possible, for instance, using the new guidelines on treatment of hospital-associated and ventilator-associated pneumonia to treat only for 7 days, and making sure to set end dates and stick to them for antibiotics can be quite helpful. Every additional day on any antibiotics does pose an increased risk for the patient for the development of things like C. diff-associated diarrhea and other antibiotic complications. So here's some take-home points. We talked about that fever in the ICU is common and that the proportion of fever which is due to infection is variable, but significant and likely around 50%. The most common sites for infection that we're concerned about are lower respiratory tract infections, so pneumonia, whether hospital-acquired or men-associated, and central line-associated bloodstream infections. The initial fever workup should include a physical exam, a clinical evaluation, as well as blood cultures, a respiratory specimen culture, and chest x-ray. Those can be difficult to interpret. And urine studies for patients for whom that's appropriate. And the appropriate urine study initially may be only a urinalysis with sediment to determine if there's pyuria or inflammation, and that would guide subsequent testing by urine culture if pyuria is diagnosed. If a bacterial infection is suspected, then empiric antibiotics should be initiated after cultures have been drawn, with consideration for empiric treatment for drug-resistant organisms such as MRSA, Pseudomonas, or other resistant gram-negatives. And broad empiric treatment is reasonable initially, but antibiotic regimens should be tailored by culture data as soon as possible, and that there are many other non-infectious causes of infection in the ICU, and also infectious causes that are non-bacterial, such as candidiasis and viral infection. So having a broad differential and a broad evaluation is important. So I'm on to the review questions. So question 1, this is a 52-year-old woman with a history of depression, which is well controlled on citalopram, as well as a history of COPD. She's a current smoker, and she's hospitalized now with a pneumonia. She requires mechanical ventilation for hypoxic respiratory failure. After intubation on admission, an endotracheal tube aspirate is sent for culture and grows MRSA. She is treated with linezolid. A radial artery catheter is placed for monitoring purposes. On hospital day 5, she develops a temperature of 103.5 degrees Fahrenheit, as well as tachycardia and hypertension. Her ventilator requirements are unchanged. The most likely cause of fever in this patient is A, serotonin syndrome, B, ventilator-associated pneumonia, C, catheter-associated bloodstream infection with gram-negative organism, D, C. diff infection, or E, adrenal insufficiency. And the correct answer is A. And the rationale for this is that the patient, just going through the wrong answers first, the patient does not have a clinical syndrome of progressive ventilator-associated pneumonia. Her ventilator requirements have been unchanged, and so that's suggestive that this is not a respiratory process that's causing this new fever. Answer B is incorrect because catheter-associated bloodstream infections are incredibly uncommon with radial artery catheters, and so that's less likely. Answer D is incorrect because we've not been given any clinical information to suggest that this is an intraluminal GI infection such as C. diff. And answer E is incorrect with adrenal insufficiency because the patient is both tachycardic and hypertensive, which would be not associated with adrenal insufficiency. The serotonin syndrome is correct because the patient has both the clinical syndrome, so she has hyperthermia as well as tachycardia and hypertension, as well as the risk factors. So she's been treated already with a serotonergic agent, that's citalopram, which is a pre-existing medication for her, and then the addition of linezolid, which is a weak non-reversible MAOI, weak reversible MAOI inhibitor, which can cause also serotonergic effects, especially in combination with other serotonergic agents, and has been associated with development of serotonin syndrome when given in combination with MAOIs or serotonergic agents in a series of patients. Okay, and then this is question number 2. A 72-year-old man with underlying severe interstitial lung disease is hospitalized with hypoxic respiratory failure. He requires mechanical ventilation in the ICU. He has a central venous catheter placed and receives empiric treatment for pneumonia despite the absence of fever. On hospital day number 4, he develops a temperature of 101.5 degrees Fahrenheit. His physical exam is unchanged. Reasonable initial measures for evaluation would include all of the following except, and the answer possibilities are A, chest x-ray, B, blood cultures, 2 sets, 1 drawn peripherally and 1 from the indwelling central line, C, fungal isolator blood cultures, D, a culture of the endotracheal aspirate, or E, blood liver function tests. And the correct answer is C, fungal isolator blood cultures. So fever evaluation for a patient in the ICU who's developing a new fever, regardless of whether he's already been on to antibiotics for a current infection or not, should include blood cultures and lower respiratory tract cultures, such as the endotracheal aspirate and answer B, and the blood culture, or answer D, I'm sorry, and the blood cultures as in answer B, as well as a chest x-ray as in answer A. And then a panel of laboratory tests, including blood liver function tests, especially for patients who are on antibiotics, which can cause some drug toxicities, such as hepatitis, which can be related to fever, or liver function tests can also be used as an initial diagnostic for a calculus cholecystitis or other non-infectious causes of fever. Okay, and then finally question number 3. A 64-year-old man with a history of hepatocellular carcinoma is admitted to the hospital with upper GI bleeding. He develops hypotension and is admitted to the ICU for transfusions, pressors via central venous catheter, and supportive care. After several maneuvers, his GI bleeding stops. However, on hospital day number 3, he develops a fever, a temperature of 102.2 Fahrenheit, and his blood pressure drops further. His pressor requirement increases. Empiric treatment with vancomycin, ceftazidime, and levofloxacin is initiated. On hospital day number 4, blood cultures drawn the previous day are reported positive for MRSA. Appropriate next steps include all of the following except A, removal of the central venous catheter, B, repeat blood cultures, C, continuation of vancomycin for at least a 14-day course, D, continuation of ceftazidime and levofloxacin for a 7-day course, and E, transthoracic echocardiogram. Okay, so the correct answer is D. So that is the correct answer because that is the not appropriate next steps to take. So this was the accept question. So why is it not appropriate to continue ceftazidime and levofloxacin? So this would be because we now have a culture that correlates with what's been going on clinically with the patient. So the patient's now been diagnosed with MRSA or methicillin-resistant Staph aureus bacteremia, which correlates well with his clinical syndrome of fever, hypotension, and has a pre-existing central venous catheter. So this is likely a central line-associated bloodstream infection with MRSA. Now that we've diagnosed the organism, ceftazidime does not have any activity against gram-positive agents, including MRSA, and levofloxacin has some intermittent activity against MRSA, but certainly would not be the treatment of choice for a MRSA bloodstream infection. So continuing either of those antibiotics would not be appropriate because that would be additional exposure to antibiotics that the patient does not need. The patient should be continued on vancomycin. The current guidelines are to continue for a 14-day course for MRSA bloodstream infection. Sort of depends on how quickly he clears his cultures, but that would be a reasonable estimate. And then repeat blood cultures should be performed to ensure that the bacteria is clearing from the bloodstream and that there's not an ongoing persistent bacterial source. And the central venous catheter at some point should be removed when it's safe to do so, because the presumption would be that the central venous catheter is also infected. And a transthoracic echocardiogram may be of limited utility since the patient developed this infection rapidly, but certainly given the organism and the risk factor with a central venous catheter, it would be reasonable to evaluate to make sure that there's not an intracardiac ongoing source of infection.